Hello everyone, my name is Hiranyada and today I'll be presenting this lecture on granulomatous inflammation. Now before we dive in any further into this topic, it is important that we understand the basic concept of what granulomatous inflammation is. So we have inflammatory cells. Now there's an infective agent or there is something that infects or causes harm to your tissue. Now, when that happens, inflammatory cells come to that particular place where the harm is being caused. And what they do is that they do a reparative and a defensive action. So they cause the elimination and eradication of that particular infective agent, and then they also play a role in the repair of that particular tissue. Now, when the body is incapable to do so, or when the particular infective agent is preventing the body from performing a proper elimination and eradication of this agent, then what our body does is that it tries to contain that infective agent. And for that, we need a separate process. And that separate process is what we'll talk about, and that is granulomatous inflammation. So we're not eradicating or removing it, we are just cordoning it off from the body or from that particular region where it is causing the problem. So, what basically is granulomatous inflammation? Now, granulomatous inflammation is a subtype of chronic inflammation which is characterized by formation of a granuloma which attempts to contain and wall off the offending agent. So if you see this picture over here, in the center you have the infective agent, and what the inflammatory cells of your body have done is that they've formed sort of like a border or a boundary around it so that it does not spread or go to different paths. So it's actually contained in that one particular region. This particular process plays a role in the protection of the hosts from any kind of severe symptoms that a particular disease might cause, and also it prevents it from disseminating, and it restricts inflammation to that particular area and reduces systemic effects. So we talked about what granulomatous inflammation is. Now granulomatous inflammation has a characteristic thing which is called a granuloma. Now what is a granuloma? Now granuloma is the accumulation of macrophages which are transformed into epithelioid cells and multinucleated giant cells. So there is epithelioid cells, multinucleated giant cells. Along with that, you have lymphocytes, to be specific T lymphocytes. There is some amount of necrosis in the center and also deposits of fibrinous collagen. Now, what are epithelioid cells? So, epithelioid cells are nothing but a modification of your macrophages. So what is the difference? Epithelioid cells have decreased phagocytic activity. They have reduced Fc and C5 complement receptors. But along with that, they have secretory function. So they have protein kinases which help in signal transmission, which are further responsible for strengthening the granuloma so that there is no leakage, and also release of cholecalciferol, which causes hypercalcemia, which causes dystrophic calcification of this granuloma. When I talk about multinucleated giant cells, a very important example for that are your Langerhans cells. These are nothing but your macrophages which are fused together. So that's a big giant cell with multiple nuclei. So that's what Langerhans cell is. Not just Langerhans cell, there are multiple giant cells, and I will put up a picture of a series of giant cells in one of the further slides so you guys can have a look at it. So we saw what a granuloma is on the next slide. So over here, I just want to show you guys the picture of a granuloma, of how it looks like. And over here, you can see that the green cells are your T cells. You have macrophages, the pink ones. They have ingested some amount of the infective pathogen. Along with that, to strengthen this granuloma and to prevent any kind of dissemination and to restrict inflammation in this area and contain it, you can also see that there is a thin rim of fibroblasts and connective tissue surrounding it right here. So this is what a granuloma essentially looks like. So before I move any further, I would like you guys to orientate yourself with certain giant cells that are important for you to know. This is a picture from Professor Dushkova's presentation. And over here, if you just follow my pointer, you can see that this is a giant cell, a foreign body giant cell in the lungs. This is because of silicosis, and the silica particle is being engulfed by the multinucleated macrophage. This is the Langerhans giant cell, which is usually seen in patients who have tuberculosis. Then down here is the epulous giant cell, which is seen in close contact with the capillaries and eventually gains its own blood supply. This is a precursor gingival lesion, and can this particular cell and lesion can convert into a neoplasm later in life. Over here we have the Aschoff giant cell. The Aschoff giant cells are usually found in the heart. And over here is a megakaryocyte, which is a thrombocyte precursor. And over here you see the Hodgkin cells and the Reed-Sternberg cells, which are found in your lymph nodes in the case of lymphomas. Followed by osteoclasts. These are your resident macrophages, which are found in bones. And your placental giant cell over here, which is the syncytiotrophoblast. And then tumors also deform giant cells. So all these things can be a differential for a particular thing that you are seeing under the microscope. So you need to remember that there are different kinds of giant cells, and also that not all giant cells are formed from macrophages or are macrophages. Right. So moving on with the topic of granulomatous inflammation. Granulomatous inflammation is divided into two subtypes. We have one that is related with the non-cassating granulomas and the one that is related with the cassating granulomas. Now, non-cassating granulomas are the ones which are also called your foreign body granulomas and are due to foreign bodies, as we saw in the silicosis example, that are too large to be phagocytized. Now, one thing to remember is that these particular granulomas will not have any kind of central necrosis and will also not have a T cell mediated immunity. So again, no central necrosis and no T cell mediated immunity. Furthermore, also remember that these particular granulomas cannot phagocytose. So they just contain the pathogen or any kind of uh, foreign body, and they do not phagocytize them. The examples for this are breast implants. They can be seen in sarcoidosis, which is an idiopathic respiratory disease with multiple non-cassating granulomas. It can be seen in patients who are exposed to beryllium or who are intoxicated with it. It can be seen in Crohn's disease in the GI tract, and this is also a major difference between Crohn's disease and ulcerative colitis, because in Crohn's disease you have non-cassating granulomas, but in ulcerative colitis you see crypt abscesses with neutrophils. So you don't see granulomas, you don't see that macrophagic epithelioid structure. What you see are abscesses with neutrophils, so polymorphonuclear lymphocytes, leukocytes, sorry. And then it is also seen in cat scratch disease, wherein you see these granulomas which are stellate shaped in your neck region. The next category of granulomas is the casseting granulomas. The casseting granulomas are characterized by central necrosis and with the T cell mediated immunity. So, what makes them different from the non cassating ones is that they have central necrosis and T cell mediated immunity. These are these granulomas are caused by tuberculosis, leprosy, fungal infections such as aspergillosis. There can also be pseudogranulomas, which are not true granulomas, and they are formed by neutrophils and necrosis. So necrosis along with neutrophils giving a similar appearance as that of granulomas, but because there are no macrophages, that is why we call them pseudogranulomas. They are whitish gray and sort of like a firm mass which is seen on an X-ray. Other etiologies for this particular type of granuloma include the lymphogranuloma venerum, which is caused in syphilis. Other etiologies are brucellosis, listeriosis, tularemia. With fungus, we can see it in histoplasmosis, and also it is also seen with parasites such as schistosomiasis and toxoplasmosis. Other than that, in case of a non-infectious etiology, we can find them with rheumatoid arthritis. In case of tuberculosis, we see a very characteristic finding on the lungs, which is called a cassating granuloma. It is called a cassating granuloma because it looks like cottage cheese, which essentially looks like a white, cheesy clump of some substance. And the main thing to know here is that in cassating granulomas, the necrosis that you see is because the macrophages are continuously phagocytizing the pathogen. So that is why they're also different from the non-cassating granulomas. On this particular slide, we'll be focusing on the formation of a granuloma. If you focus on this diagram, you can see that the pink colored cell is a macrophage. The macrophage engulfs the mycobacterium and prevents it from spreading. This process is done because of endocytosis. Following this, the macrophages release the tumor necrosis factor and signal the dendritic cells to recruit T cells. These antigen presenting cells then present the foreign antigen on the major histocompatibility complex MHC class II to the CD4 plus helper T cells. This induces the secretion of cytokines, which results in the conversion of CD4 helper T cells to the Th1 subtype. Following this, there is a release of the interferon gamma, which enhances the macrophage's response and increases T cell recruitment. This process also affects and strengthens the macrophages and leads to their conversion to the epithelioid giant cells, thus leading to the formation of such a granulomatous structure. Since we are talking about Mycobacterium tuberculosis, it is also important to note that there is a molecule called the trehalose 6,6 dimycolate, which is also called TDM. This is one of the many lipids in the mycobacterial cell wall. The function for this is that it is so toxic that it causes and it also potentiates the formation of the granuloma. It is the most abundant extractable lipid from the surface and the cell wall of the mycobacterium. The purpose of this particular molecule is that it inhibits the phagosome-lysosome fusion. Thus, the proper function of the macrophage is not performed, and that is why there is a formation of the granuloma. Once the granuloma is formed, there are certain processes that lead to its progression and determine its fate. So once the granuloma is formed, there is progressive growth of the granuloma. So the granuloma increases in size. There is increased necrosis within the granuloma itself. Once that happens, sometimes there's formation of a cavity, or there is spread with generalization or metastatic foci. Now, what does that mean? In case the granuloma is not very strong, there can be a leak or a burst, and this granuloma can leak and spread and the pathogenic contents can spread through the body and go and seed anywhere else. And that can lead to a generalized infection or maybe a metastatic infection. Following this, there is also a regression in the granuloma. Now, regression means that the granuloma is either getting dissolved, there is healing, and these processes are characterized by either fibrosis, formation or deposition of hyaline or collagen, or dystrophic calcification. Before I end this particular topic, I would like to emphasize on three very important terms. The first one is chronic granulomatous disease. It is an inherited genetic mutated disease which reduces the ability of the neutrophils to kill certain bacteria like Staphylococcus aureus and fungi like Aspergillus. This is because in patients with chronic granulomatous disease, there is the deficiency of NADPH oxidase and the reactive oxygen species are not formed. Individuals with such a disease are highly susceptible to infections that can lead to formation of granulomas throughout the body and not just in a particular organ. Defective phagocytic activity and NADPH oxidase cause this disease, and ultimately this results in the inability of phagocytes such as neutrophils, monocytes, macrophages to destroy certain microbes. The second one is granuloma annular. It is a chronic skin disorder, as you can see in the picture here, and it is characterized by granulomas appearing on the skin. They can vary from being small and red to yellow bumps like that of a ring. The third one is the granulomatosis with polyangiitis. This is a rare autoimmune induced vasculitis which is characterized by granuloma formation causing inflammation of blood vessels, primarily small sized arteries, and ultimately affecting the blood flow. The purpose of mentioning these three is that they can be important in your differential diagnosis with regards to other granulomatous conditions. Thank you so much for your attention and hope to see you guys in the next lecture.